Matt, I was thinking about signing up for a Pilates class.
Okay.
And I was talking to the instructor, and he said to me, well, how flexible are you? And I said, well, I can do Tuesdays or Thursdays. You're never as happy with mine as I am. I'm going to stop trying, I think.
Well, Paul, I just wanted to say, with great reflexes comes great responsibility.
And yet you were withholding with mine. It doesn't make any sense.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hey, Paul.
Hi, Matt. How are you?
I'm doing well, Paul. We just recorded a fantastic episode. I learned a lot. We were talking about hypermobility spectrum disorders and hypermobile EDS, or Ehlers-Danlos syndrome, something, Paul, that until very recently I knew nothing about. I don't know about you, but that's my life.
It is a topic I continue to find bewildering, though I feel much better about it after this episode, as is often the case.
Yes, and our guest was the great Dr. Linda Bluestein of the Bendy Bodies podcast. We'll tell you more about her in a second. But Paul, what do we do on this show? And I haven't asked you this in a while, Paul. Why are we doing this show?
What are we doing with ourselves, Matt? What are we doing to ourselves? But we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And Matt, we're doing it to make the world a better place. And as you mentioned, we had a great conversation with Dr. Linda Bluestein. Dr. Bluestein is a leading expert in hypermobility disorders and the founder of Hypermobility MD. She also leads at Bendy Bodies, a coaching service empowering individuals with hypermobility to optimize their well-being. She hosts the Bendy Bodies with Hypermobility MD podcast, offering valuable insights to the community, and is an advocate for hypermobility research, serving on multiple advisory boards. Learn more at www.hypermobilitymd.com. So, Matt, on this episode, we learned a little bit about the general presentation of hypermobility and how that differs from laxity and why that might be important. We talk about some of the related things that we may see with generalized hypermobility, including things like POTS and some of the other syndromic stuff that might ride along with joint hypermobility, in addition to the sort of more classic manifestations. We talk about what people might benefit from genetic testing, what people maybe you don't need it for. And then also we talked about sort of broad management principles in as much as we were able to in the time that we had. It was a really helpful episode. I feel like I learned a lot and have a much better framework coming out of it than I did going into it, for sure.
All right. So without further ado, let's get to it. And a reminder that this and most episodes are available for CME credit through VCU Health at curbsiders.vcuhealth.org. Linda, welcome to the podcast. Thank you for joining us, and we're excited to talk about hypermobility. But first, the audience wants to know, what's a hobby or interest that you enjoy outside of medicine?
Well, if people have already listened to my show, then they would definitely know this, I would think. But ballet is my most favorite hobby. I love to watch it. I haven't taken a class in a really long time, but anything ballet related, I'm in.
Paul, you have a background in ballet, right?
It's notorious for my flexibility, and certainly my knees don't pop whenever I make any sudden moves.
Okay, so I guess not.
And then another question that we like to ask is, any advice or feedback, either that you've received or that you like to give to trainees that you've amassed during your lifetime?
I think I would probably say the most important piece of advice is that it's normal and natural to feel like you don't know enough, because especially now, right, there's such an abundance of information. So don't panic if you feel like you don't know enough. I don't know about either of you, but when I finished my residency and I started my first job, I was an anesthesiologist by myself. I had a few nurse anesthetists I was working with, but it was very scary. I went from the Mayo Clinic, where I was working with, tons and tons of anesthesiologists, to being by myself in this small hospital. And it was scary, and I felt like I didn't know enough. And of course, you learn a lot in your training, but you learn a lot throughout your entire career. So I just think it's important for people to know that they're not alone if they feel that way.
And just getting used to pulling the trigger on decisions by yourself,
Yes.
especially if you're like putting people under anesthesia, that seems like that would be a lot more scarier than me just like prescribing a blood pressure medication without an attending for the first time.
Yeah, right. And I remember several times that once I was in a group practice and I asked somebody else like for another opinion because the person was kind of complicated. And almost every time I kind of regretted it because it just turned into like this big thing. And it was like I was on the right track with my thought process. And, not that you shouldn't consult with your peers. Of course, it's great to do that. But
Yeah, you were ready. You were more ready than you knew, I guess.
right.
Well, yeah, maybe you could say Paul and I started a podcast to to make us feel better about practice and more confident by talking to experts in everything that we had questions about, which is what we're doing here tonight. Paul, so speaking of, let's get to a case and then let's start asking some questions.
Let's get to a case. I do want to mention this case was adapted fairly heavily from a really excellent paper on diagnosis and management of hypermobility spectrum disorders in primary care from the Journal of the American Board of Family Medicine by Atwell et al. So I just want to give credit where credit was due because it was such a nice framing and I couldn't do much better. I couldn't do any better. What am I saying? But in any case, our case today, we're going to talk about Ms. Jones. Ms. Jones is a 23-year-old female. She presents to your primary care office with diffuse muscle and joint pain. She states that she just feels tired all of the time. The pain that she experiences is most intense in her knees, her ankles, and her feet, and this has been going on for at least 5 years, probably longer. She has had such knee pain at one point that she even had previous imaging of the knees that showed no significant pathology, kind of unsurprisingly. She does say that she is double jointed and that she has sprained her ankle multiple times, but is not really sure how that's related. In regards to her feeling tired all the time, she says she actually gets a fair amount of sleep. She sleeps between 8 and 10 hours a night, but when she wakes up, she still feels like she still can't make it through the day without falling asleep. She does have a past medical history that is noteworthy for anxiety. She gets chronic headaches. She said maybe someone diagnosed with IBS, constipation, varietal in the past, but the details are not fully clear. She also mentions, as you go through your review of systems, that sometimes she gets dizzy and she gets heart palpitations when she stands up. She stands up and just feels kind of off and feels her heart racing and feels like she's about to pass out, but never has. So, Linda, before we get too deep into the case, this is our joint hypermobility episode. Could you just give us a broad definition of joint hypermobility? And yeah, let's just start with that question.
Well, I have to just say, it sounds like maybe this person was like listening in on my clinic or something like that, because man, that describes an awful lot of people that I see. But obviously, we're going to get into that in more detail. So joint hypermobility means that a joint or a group of joints has greater than expected range of motion. And it can be completely asymptomatic or it can be problematic. So it varies a lot depending on the person.
Yeah, and I think this history, we're fortunate with this history. In the regular primary care office, I would say you get some of this, but maybe not so packaged like the way this is.
Right.
And I'm not sure how important it is, but I'm going to ask just because in the reading that I've done for this, there was a lot of hay made out of there's a difference between hypermobility and joint laxity. Is there a point differentiating or can you differentiate that for us?
There's a very important point there. So joint hypermobility refers to the range of motion. So for example, for those that are watching on YouTube, I'm going to show my elbow. If my elbow hyperextends past a certain number of degrees, it has to be more than 10 degrees in order to be considered positive for hyperextension. That just tells you the range of motion, but it doesn't tell you how the bones are moving in relation to each other. So if you have joint laxity or joint instability, that means that the bones have difficulty staying in proper alignment. Joint instability or joint laxity is probably more important than joint hypermobility. However, it's harder to assess for. So usually when we talk about these conditions, we talk about the hypermobility aspect.
And how common is this? You mentioned it can be symptomatic or I think you said it even better. I think you said problematic or non-problematic, I think was your framing of this. But I guess how much can we expect to see? This is probably only partially relevant. That's kind of what I do. But now that I've been looking at a lot of noses, because it's cold and flu season, I feel like I'm seeing a ton of deviated nasal septa, which has nothing to do with anything. But I'll tell the patient, your septum's kind of deviated. They're like, what do I do with that? I'm like, nothing. So again, along those lines, I guess I'm wondering if we looked for it, we probably see a lot more than we're actually talking about in clinical practice. And this is my long-winded way of asking about how prevalent is joint hypermobility. Do we have a sense of that?
So if you look at high-risk populations like elite ballet dancers, you're going to see like 90% of them have some degree of hypermobility. But if you look at more quote unquote normal people, you're going to see more like in an adult population, like maybe 20% of people have some degree of hypermobility in their joints. But then a subset of that will have connective tissue disorders like the Ehlers-Danlos syndromes. But joint hypermobility itself is more common in children, and it's more common in females than males, and varies depending on a number of other factors.
Can you tell us from this history, like what jumps out at you, where you might be keyed in on hypermobility, and if there's anything else missing that you would want to ask about?
So yeah, I definitely, this person is describing multisystemic symptoms, which definitely fits with the picture that I commonly see. The Ehlers-Danlos syndromes are a group of connective tissue disorders. They're actually the most common hereditary disorders of connective tissue, and there's actually 14 different subtypes. And of those subtypes, the hypermobile type is the most common type. So this person is describing a lot of features that sound to me like it could be hypermobile Ehlers-Danlos syndrome. So the other subtypes can be diagnosed based on genetic testing, but the hypermobile type, we don't actually know what the genetic marker or markers are yet. So it sounds like based on the description and the features and things like that, I don't really suspect one of the more rare types. I more suspect the hypermobile type. If a person doesn't have enough features to meet the criteria for hypermobile EDS, then usually the diagnosis would be HSD, or hypermobility spectrum disorders. And hypermobility spectrum disorders are a classification that was introduced in 2017 by the International Consortium on EDS and HSD, and they introduced this new diagnostic category for people who no longer meet the newer, stricter criteria for hypermobile EDS.
Yeah, so is it almost like we can think of it as a spectrum where the hypermobility spectrum disorders, they have some of these features of hypermobile EDS, which we're going to talk about, but they don't have enough to meet the official criteria. That's it.
Yeah, I agree with that. The tricky thing is that there are people with HSD that are actually more impacted than some of the people with hypermobile EDS. And that's where, although the word spectrum is in HSD, I just like to be a little bit careful about that, because sometimes when I am evaluating someone and we're basically looking for the three core features related to the Ehlers-Danlos syndromes, which are, again, the joint hypermobility. We're looking for changes in the skin. So we're looking for skin hyperextensibility. We're looking for, things like bruising. We're looking for atypical scarring, things like that. And then we're also looking for weak tissues. So that could be represented by, multiple hernias, mitral valve prolapse. They could have pelvic organ prolapse. And there's a whole checklist of criteria that we look at. And I tend to think more of people with hypermobility spectrum disorders as more musculoskeletal problems. They still could have some of the comorbidities like POTS, which is a form of dysautonomia. And I'm sure we'll get more into that later. Or they could have mast cell activation syndrome, which is another one of the comorbidities. And the tricky thing is there's a lot of overlap then with the way that these different things present. So the mast cell activation syndrome or the dysautonomia can cause an irritable bowel-like picture. So the irritable bowel symptoms could be related to connective tissue being suboptimally strong, or it could be related to the mast cells being less stable, or the autonomic nervous system. So it gets complicated kind of fast, or there's, these different factors involved.
I'm glad I asked that question, because that's such an important point, that just because they don't meet the full criteria for hypermobile EDS, if they have one of the spectrum disorders, it could be more severe. They could be more affected. That's somehow I didn't gather that from the reading, so I'm glad you were able to correct me about that on air, because maybe that's a common misconception.
It's a very common misconception, and it's something that frustrates a lot of patients, very understandably. And the criteria are very much in flux. So there's a project called the Road to 2026. So we have a current set of criteria, but that criteria is being revised as we speak. And we will probably know the new criteria even at the end of 2025. So it's very important that we explain to patients that this is definitely an area of really fast research, and we're trying to learn as much as we can because a lot of people are suffering. Millions of people are suffering.
Yeah, and to take it back to Matt's question, probably a lot of that has to do with sort of lack of recognition, I would think. Like, this is So to recap, this is a 23-year-old patient who has some fatigue and some diffuse joint pain, even though the imaging's been okay, who's tired all the time but sleeps all right, has prior anxiety. I could easily see this being diagnosed, or a diagnosis of anxiety sort of being forced upon this patient. Like there's some somatoform stuff, and they're probably just anxious, and I start an SSRI, and then they wouldn't really feel much better, and I blame the patient or something along those lines. So I guess going through this history, could you sort of point out the things that would make you, that would sort of trigger you to think, oh, this could be somewhere, this could be joint hypermobility and not just a broad syndromic thing that I don't understand well.
Right. So the double jointed is, probably the biggest thing that jumps out that, was described in this 23-year-old's history. So that's really, really important. And that's part of what's called the 5-point questionnaire. And I love the 5-point questionnaire because it really focuses not just on current joint range of motion, but also past joint range of motion. So I'm going to be 60 in a couple of months. And I used to be very bendy as a ballet dancer. I wasn't the most bendy person in the room, but I was pretty bendy. And I'm not at all anymore, So it's really important not just to focus on what's going on right now, but how the person was in the past. So this 5-point questionnaire asks, did you used to do party tricks and entertain your friends? And I would point, pop my joints in and out. I'd put my legs behind my head. I'd crawl around on my elbows, all kinds of stuff. So it's really important to ask those questions. And that's the first thing in the history that really, to me is the most specific, because a lot of those other findings are things that we see with a lot of conditions, but that double jointed phrase right there is really key.
I'm still shocked that you said you were almost 60. People watching the video.
Yep, same.
So you're aging well. That's good. We'll talk about that on another podcast with you. So I was reading that there's a long lapse between symptom to diagnosis with this. And I was never really taught to ask about hypermobility in any of my, just as an internist, I never ask about hypermobility. Now I'm thinking that I should be, but it's just not like a general review of systems question that you'll find on any of the like boilerplates we give to our med students, like ask about these things.
Mm-hmm.
So what do you think about, like, do you think that's one of the main reasons? Why do you think it's such a long time to diagnosis?
Yeah, I think for a variety of reasons. One is, I think, like another thing in this person's history was the multiple ankle sprains. But a lot of people get ankle sprains. It depends on how physically active you are. And there's a lot of things that can cause that, of course. So it's, and we know that a large percentage of people are hypermobile. So even the double jointed part, it might clue you in, but it doesn't mean for sure that it's problematic. I actually have a friend who, thank you so much for the compliment, by the way, Matt.
You're welcome.
I appreciate it. I have a friend who just turned 65, and this woman looks freaking awesome. And she was a bodybuilder, and she came to my house for dinner. And next thing I know, we're talking about hypermobility. I work it into pretty much every conversation that I possibly can. And next thing I know, this is the first time she ever comes to my house. She's on the floor doing the splits. So here's somebody, she's 65 years old. She's extremely healthy, extremely fit, but she's crazy hypermobile. She's doing all the tricks. She can, do the prayer hands behind her back, with the hands pointing upwards, and she can do all these different tricks. She could touch her thumbs to her forearms, and she could do these things. So it's not always a problem, but it's very important to ask in somebody who's complaining of, widespread pain, abdominal symptoms. They're dizzy when they stand up, which is, of course, suspicious for orthostatic intolerance. So for those patients, asking the 5-point questionnaire or including that in your intake paperwork is so easy to do. People can look it up. It's literally 5 questions where you ask, it's yes or no questions. And if they answer yes to 2 or more questions, that's highly suspicious for generalized joint hypermobility. And I should explain actually what that is. So when I said joint hypermobility is greater than expected range of motion or of a joint or a group of joints, there are actually 4 types of joint hypermobility. So peripheral joint hypermobility is in the hands and the feet, but not other places. Localized joint hypermobility is in like 2 or 3 joints, but no more. And if you have generalized joint hypermobility, that's in like 5 or more joints. So that's diffusely throughout the body. Historical joint hypermobility means that you were hypermobile in the past, but you're not anymore. So what I like about the 5-point questionnaire is because this is a very good test for generalized joint hypermobility. And if someone has generalized joint hypermobility, that's when you're more suspicious about a connective tissue disorder.
Okay, so five or more joints. Got it.
I just want to be explicit about the questionnaire and actually go through the questions if that's okay. Just because we've
Of course.
talked about it, I think we've touched on some of the points, but the 5 questions are, and please correct me if I'm wrong, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your kneecap or shoulder dislocate on more than one occasion? And 5, do you consider yourself double jointed? And as you said, an answer of 2 or more of these suggests hypermobility, which is, it's pretty good. It looks like sensitivity is 85%, the specificity is 90%. So this is a good initial screening test if you start to have, if this is a diagnosis you're starting to consider.
And again, that screening is for generalized joint hypermobility. So it's for that specific type, which could be historical or not. Sometimes people think it's a test for EDS, and it's not. It's a test that those questions are for generalized joint hypermobility. So, but thank you for going through all of them, because that's great.
So let's bring it back to Ms. Smith, the inventively named Ms. Smith. So she says she's always been able to bend over and place her hands flat on the floor. She says that she used to entertain her friends by bending her body to different contortions. She does consider herself double jointed, so far we're doing great. She can, in fact, bend her thumb to touch her forearm, but she does deny a history of elbow or shoulder dislocation. So based on this, we are suspecting some component of joint hypermobility because we are very good internists. And somewhere, at least in my brain, the phrase Beighton scale perhaps emerges, though I'm never quite sure when to use this or what to do with this. So could you tell me a little bit more about, so we've done this sort of initial screening for generalized hypermobility. When does the Beighton scale come into play? I feel like that's one of those things we've all kind of heard of but never quite know when to use and forget that it exists. So can you tell us a little bit more about its utility and when it is useful to us?
Sure. So the Beighton score is kind of tricky because it looks at, there's actually multiple points for the upper extremities. There's 6 points out of the 9 that you get from the upper extremities. So first it's, you actually have the patient touch their thumb to their forearm on both sides. And you get 1 point for every maneuver that you can do, by the way. And then you have them bend back their 5th finger. And if they can extend it more than 90 degrees, then you get a point for that. And then the next 2 points are for the elbows if you can extend those more than 10 degrees. So 6 of the 9 points are from the upper extremities. So like in my work with dancers who get more injured in the lower extremities, you can see where this is already a problem, right? So I often do the Beighton score, but I don't put a lot of weight on it because we know that there's many, many more joints in the body than the ones that I just described. The other points are from knee hyperextension. Do the knees hyperextend more than 10 degrees? And then the last point is, can you put your hands flat on the floor without bending your knees? Now, you can imagine, because a couple of these points overlap with that 5-point questionnaire, I used to be able to do that, touch my thumbs to my forearms, but I can't do it anymore. I had major surgery, bone grafting surgery in this wrist, and I have a lot of arthritis, so I can't do those things anymore. But I used to be able to. So that's why I love the 5-point questionnaire. I also will examine, their painful joints and problematic joints and things like the shoulders. Shoulders are inherently unstable joints, right? We see a lot of problems with the shoulders, with instability and things like that. And the shoulders are not included in the Beighton score. So the Beighton score can be very helpful, but at the same time, it should only be one small piece of our assessment.
Seems like not the value changes, but the scores naturally are affected by things like aging, I think, as you mentioned, as well as by biological sex as well, right? So there are some limitations just in terms of even sort of fundamental interpretation above and beyond other comorbidities or other kind of complications, it sounds like.
Right. So in an adult, we're looking for a score of greater than or equal to 4. And in post-pubertal, we're looking for a score greater than or equal to 5. And like in a lot of dancers, we look for, okay, do they have a score greater than or equal to 6? So some people have actually proposed in dancers that we take out the point where they put the hands flat on the floor without bending their knees because they train to do that. So is that really actually valuable?
I've never been able to do that. I definitely, I would have a very low score on this Beighton scale, Paul.
Would you?
I think it would kill me, actually, if I tried to do most of the things that we're trying here.
I do want to say one really important thing. I'm really glad you asked about the Beighton score. I have heard of some people where when they're looking at a patient, they will physically, I've heard this from patients, I should say, that where they'll actually take their hands and and bend them and try to force their thumb onto their forearm. And I never touch a person when I'm having them do this. I have them do the maneuvers themselves, and I tell them, don't hurt yourself. Don't force anything. If you can't do it, you can't do it. It's, it's more for, information, and it's kind of more interesting, more so than it's going to really change that much how I approach your care and or the diagnosis. If you have historical joint hypermobility, but you meet all the other criteria for hypermobile EDS, I'm still going to diagnose you with hypermobile EDS. It's a genetic condition, so it didn't go away just because your joints got more stiff.
Yeah. I don't know if now's an okay time for this, but do you talk to patients about the natural history of this? Like if you're diagnosing someone with generalized joint hypermobility, how might you talk to them about that and what it means, what it might mean for the history?
I definitely talk to them about that, especially if they're a younger dancer and, we don't know then, right? We don't know if they're going to be like my 65-year-old friend who is in incredible shape, or are they going to be somebody who's going to develop a lot of symptoms? So especially if they're young, I really talk to them a lot about ways that they can protect their joints, keep their body strong, provide their body with really good nutrition, and stay active as long as possible. So whether it's through dance or some other form of activity, we definitely want people to be moving in ways that are safe and listening to their body and things like that. Mm-hmm. But yeah, it's really important to talk to people about that. A lot of people, I feel like, think that these are always progressive conditions. And at least for me, I'm doing way better now than I was about 15 years ago. So it can be progressive, definitely can be progressive, but not always. And I probably just threw that in there without saying I have a diagnosis of hypermobile EDS. So I don't know if I mentioned that yet.
I don't think you have yet.
I don't think so.
Okay.
Yeah. Okay, that's helpful. And I'm sure if people are listening and they have this, or if they have patients with this, they're reassured to know that it doesn't have to be a progressive condition. And we're going to talk about things we can do, protective things we can do. Paul, what's next on your agenda for this? Like, do you want to get into the specific criteria for diagnosing hypermobile EDS? Because we've sort of talked about how to diagnose generalized joint hypermobility. What do you think's the next step?
I think before we get too granular, I would just like to actually hear the general physical examination. So you already touched on you're not trying to ratchet someone's thumbs or forearms or make themselves, you're not forcibly bending them in half. But when you begin to suspect joint hypermobility, I'd love to hear what your physical examination looks like and sort of what you go through to either confirm or refute the diagnosis.
So my physical exam is going to depend a lot on, is the picture primarily neurologic? And then I'm going to, be doing a more detailed neurologic exam with, reflexes and, strength testing and things like that. I pretty much always have them walk first so I can observe their gait and, things like that. But I'm going to do a musculoskeletal exam and or listen to their heart and lungs and things like that. Always do a skin exam. Very important to look at the skin, look at any surgical scars that they have. I look to see how stretchy their skin is. So, I'm going to look at their neck. I'm going to look at the anterior aspect of their forearm as well, and see if that stretches more than 1.5 centimeters, and looking also at their neck. And I'm also going to be looking at, like I said, the abnormal scars, and then also looking for if they have stretch marks that are unexplained. So do they have stretch marks prepubertal and or without any weight gain? So because that's another, potential sign of a connective tissue disorder.
Yeah, tell us about the measuring a 1.5, the forearm. So you just pinch the skin on your forearm and... Yeah,
the anterior aspect of your forearm.
And you take a ruler and just see if it's more than 1.5.
To be honest, I don't usually take a ruler.
Yeah. Okay. I guess if you do it to enough patients, you kind of get a feel for things.
Yeah.
Okay. Paul, does that satisfy your, as the physical exam nerd on the team, Paul, does that satisfy you, or you need more details?
I would love to know. I feel like I've every paper that I've read on this talks about velvety skin findings, and I'm still not entirely sure what that means. So I would love to know if you can sort of elucidate a little bit more on the skin findings above and beyond the striae. So what other stuff we should be looking for to either rule and erupt connective tissue disease.
Yes, thank you for mentioning about the soft, velvety skin. Yes, because that is one of the skin findings that you can see. And of course, it's hard because that's really subjective, right? So I actually do now like to pet as many people as possible so that I have the widest possible data set, because everyone's skin feels a little different. And it's like, how moisturized is it? But when you really feel soft, velvety, like doughy skin, you're like, oh my gosh. So it varies. Not everybody has skin that's that crazy soft and doughy, but some people do. And by the way, I should point out too that if their skin is really stretchy, then we should be thinking about another subtype of EDS. And that's really important because you don't want to miss one of the genetically defined types of EDS. And I also want to specifically mention that vascular EDS has some very specific presentations, and that's the most life-limiting form of the Ehlers-Danlos syndromes. So it's very important to recognize vascular EDS if a patient presents with things that might be consistent with that. So those are things like, pneumothorax. They're not going to have a little bit of bleeding. They're going to have a lot of bleeding. They might have the characteristic facial features like, deep set eyes. They might have the lobeless ears, thin lips, thin nose. They might have other things like clubfoot. They might be born with dislocated hips, some things like that are really, quite specific.
Okay, yeah. So Paul, I guess that gives you license to just start petting everybody's skin.
Finally.
It might not work for Paul and I as two guys in their 40s to be petting everybody, but
The forearm. That's where I always do it, on the forearm. But I still get to what you're saying.
Yeah. Linda, I was going to ask about there was something about fragile skin in the diagnostic criteria. So with other types of EDS, is skin fragility, like how do they define that? Is that something you define on exam, or is it more like a history where they're just tearing their skin all the time? I wasn't really sure what that meant.
Yeah, it's if you think about older people who have a loss of collagen, right? So then you can take a Band-Aid off and you take off skin, or you might actually tear the skin when you take the Band-Aid off. You're going to see similar kinds of things. You don't always. Not everybody has all of these things, of course. You just have to have a certain number of them.
Okay, so you have to have a certain number of the criteria for skin, but with hypermobile EDS, which is what we're talking about on this episode, they shouldn't have that really fragile skin where you pull a Band-Aid off and you're tearing their skin. Is that pretty much not usually part of it?
They can have fragile skin.
Okay, they can.
Yeah, but their skin shouldn't be overly stretchy. I don't know if you've seen those circus, I don't want to say circus freaks, but you see these pictures online of people that are pulling their skin way out, like 8 centimeters or something, from their neck. If you see that, then you definitely want to suspect a more rare subtype of EDS.
Okay.
And then you want to do genetic testing if you suspect the vascular form or one of the more rare forms. But people who have hypermobile EDS may still have fragile tissues. An example that happened to me was, doing like a waxing for hair, and obviously that's something that's kind of traumatic. It doesn't feel good, but normally you don't tear your skin, and my skin tore, and it was like a lot of bleeding from that.
Oh my gosh.
Yeah.
It sounds like what's 40-year-old virgin, Paul. You ever see that scene where they're
Fortunately, my back wasn't quite that hairy.
All right. So I guess we should do a little bit of a recap. I know we're going to talk a little bit more through. I just want to recap some of the terms. So we talked about joint hypermobility is where there's range of motion that's just more than expected. If it's generalized, it has to be 5 or more joints. And we should ask if they, at any point in their life, had hypermobility, because, depending on where we're meeting them in the process, they might not be as flexible anymore. And then Paul made the astute point of asking about laxity, because laxity is what actually is important, because it implies instability, and that's how people are getting hurt. And with hypermobility spectrum disorder and hypermobile EDS, we're going to talk about all the diagnostic features for hypermobile EDS in a little bit more detail. But in general, hypermobility spectrum disorder are people who don't meet all the full criteria, but they could have more severe disease and they could be more severely affected. It just depends on the case. For hypermobile EDS, they have joint hypermobility. We're looking for skin changes and evidence of weak tissues. You mentioned hernias and prolapse, things like that. And we have diagnostic criteria that were out in 2017 for hypermobile EDS. I guess maybe we're going to have some new diagnostic criteria by the end of 2025 that will be out in 2026. And we used the 5-point questionnaire to diagnose generalized joint hypermobility, other features like dysautonomia, IBS, POTS, or maybe even mast cell activation syndrome. So let's start talking about some of these non-MSK features that might be present with these conditions.
So fatigue is a really, really big one. I was surprised when I opened my clinic to find that people, next to their concern about pain, that fatigue is the next most common problem that people have. And it's really problematic. I mean, they're just exhausted trying to get through the day quite often. So that's a really important thing to ask about, because there could be a lot of causes, right? So even in thin young women, which are not our typical, patient type for sleep apnea, obstructive sleep apnea particularly, it might be worthwhile to get a sleep study, because it's possible that they're so fatigued because they have sleep apnea. If their tissues are more, or if they're weaker, then they're more likely to collapse their airway when they're sleeping and obstruct their airway.
Anything else? I mean, our normal, we've done shows on fatigue before, talking about, just you ask about depression, you ask about kind of uncontrolled mood disorders, the whole biopsychosocial approach of just sort of what's going on in your life. Are there other things that could be contributing, kind of sucking out your energy, and then just general labs. Paul, what do you order in everybody? Lyme testing?
Oh, sure. Need Lyme titers.
I mean, in our area, it's reasonable to order Lyme for a lot of the time, but yeah, so thyroid, CBC, make sure they're not anemic, make sure their kidney and livers aren't like failing. But anything else that you're recommending out of the ordinary for patients with fatigue in your clinic?
So if somebody's really concerned about the fatigue, even if they don't have a lot of orthostatic type symptoms, so, they get dizzy when they stand up and that kind of thing, or they have temperature intolerance, I often will still do orthostatic vital signs, like 10-minute orthostatic vital signs. So I'll have them lay down for 10 minutes, get a baseline heart rate and blood pressure, and then I'll have them stand up and do, well, you can call it the Nassau lean test. Some people call it that, because you have them lean against the wall, and then you're going to do a heart rate and blood pressure readings about every 1 to 2 minutes for a full 10 minutes. And what you're looking for is not just for the heart rate to go up initially, but you're looking for the heart rate that either goes up, comes down, goes back up, and then kind of stays there, or goes up and stays there. So it's very normal when you stand up for your heart rate to go up, but usually it's going to come back down. And in people that have POTS, or postural orthostatic tachycardia syndrome, fatigue is a very, very common problem that you see with that condition, and they will experience an increase in their heart rate that's going to be greater than 40 beats per minute if they're 19 or younger, and an increase of 30 beats per minute or more in an adult. And that's the criteria. So you have to have these symptoms present for 6 months or more, and you have to have that heart rate criteria. You also can't have your blood pressure go down by more than 20%, because then that would be compensatory heart rate changes in compensation for orthostatic hypotension.
When you do the orthostatics the way you were talking about, do you have them lay supine for 10 minutes? Do you check a blood pressure seated, or do you just have them go from supine to standing and then lean against the wall?
Yeah.
And how are they leaning against the wall? I haven't seen this done. Are they just sort of standing with their feet, like their heels like 6 inches from a wall, and they just kind of lean back into it? Or
Exactly. So I normally don't do a reading with them sitting up. I normally do it with them supine. Then I have them stand up, lean against the wall. Like you said, their feet, their heels are maybe 6 to 8 inches away, and the wall is supporting them. So I don't have a tilt table in my office. Doing formal tilt table testing is great, but it can be miserable for patients, of course, and more expensive. And so this is a way of seeing what their orthostatic tolerance is in a more accessible manner.
I really like that, Paul. Have you heard of that before? That's pretty cool.
I have not. Yeah, this is good stuff.
All right, Paul. See, look at that. We're accidentally getting some awesome physical exam pearls for you. You got to be excited about that.
Intentional. We're master educators, Matt. I guess so this is sort of one way to assess for the dysautonomia that you might see associated with joint hypermobility. I guess I would ask, what other potential manifestations of dysautonomia should we be mindful of or be looking for as we're taking our history and neuroexamination?
So a really, really common one is temperature intolerance. So it could be heat intolerance or cold intolerance. My husband always teases me because, he can be it doesn't matter the temperature. He can either have a jacket or not, or, he's still gonna be okay. And I have, like, this little tiny narrow range of, I'm constantly layers on, layers off. And my patients are like that too. In fact, it's not a physical exam tip, but it's just a kind of a little clinic tip that when I first started my practice, I had a heater and a fan in my office space where I would examine the patients, and I would hand them both remotes, and I would say, "Just do whatever you need to make yourself comfortable, and I will adapt." So, that temperature intolerance is a big one. We also see a lot of GI problems. So gastroparesis is a very common thing. So they'll get full very quickly, and they might have also a lot of nausea. Nausea and vomiting are common, especially first thing in the morning when they first get up.
Yeah, I was reading about just after certain meals, like people just like get a lot more abdominal distension as well.
Mhm,
Like after
mhm.
they get they're more prone to bloating and those things. So uh,
Yeah.
c- some patients just seem to be, we've done disorders of gut-brain interaction talk, and some people just seem to be much more prone to that. I always thought of it as more of like a nervous system thing, but I never thought to think about, is the actual connective tissue hypermobile in the abdomen causing them to be more prone to distension on top of the dysautonomia? I guess
Mhm.
maybe in this case it is.
Yeah, definitely. I think that those can be factors as well as food intolerances. So people who have mast cell activation syndrome can be intolerant of different foods. And the tricky thing with that is it can vary day to day. So things that are pretty well tolerated one day can be problematic another day. And definitely postprandial symptoms like bloating can be really, really tough for people.
Mhm. Any other systems involved? I mean, we gave our patient had headaches, anxiety. Like, so what CNS symptoms other than fatigue, if we're considering that a CNS symptom, what else? What else should we think about?
So neurodivergence is very, very common. So we see much higher rates of ADHD and autism, like odds ratios of 7 to 8 for things like that. So that's very, very common. We see things like, dyslexia, dysgraphia, dyscalculia, the Tourette's. Those things are quite common. And things like headache, especially migraine, very, very common. We have higher rates of Chiari malformation. So we can get, different brainstem problems with that. So maybe balance problems, coordination difficulties, swallowing difficulties. You can see, different problems with the cranial nerves. So you might have blurry vision. You might have, double vision, things like that. So tinnitus is also quite common, and tinnitus can be multifactorial.
I have to imagine this might be beyond the scope of this episode, but the ADHD must be a nightmare to treat because I can't imagine these patients respond super well to stimulants if they're already
Right,
sort of tachycardic and
right.
sort of anxious and have heat intolerance. Like I can't imagine sort of throwing a stimulant medication at this person would make those symptoms much better. It just has to be a real challenge to treat, I would think.
Yeah, it's really challenging, and if people have dysautonomia, then oftentimes, they're trying to eat more, salt and water, and so, I've had people too where they're doing that and they get hypertensive, and now you're trying to, you know somebody is trying to treat their hypertension, but at the same time, like, are you because you're doing all this salt and, water is maybe the better thing to try to see how they tolerate less salt and less water, not to dehydrate them, of course, but I've had patients where the internist is prescribing something for their hypertension, but really what we just needed to do was back off on the salt and the water. Likewise, I've had patients that are on stimulants and they insist that the stimulants are not contributing to their tachycardia or to their orthostatic intolerance. I often try to convince them, though, let's just try going off. You can always go back on, but let's just try, going off and seeing what happens with your heart rate. And sometimes it really does help.
And I guess the other question I had, I mean, I have many questions, but in terms of, we alluded to there's often a delay in diagnosis. There's often symptom invalidation. These patients feel disregarded oftentimes by the healthcare system and have a hard time finding providers that they actually establish a therapeutic relationship with. All of which is to say, I guess, how common are some of like the mood disorders or other indicators of behavioral or psychosocial stress? How common do you see that in this particular patient population?
So we see huge amounts of overlap with anxiety. anxiety and hypermobility are very, very commonly co-occurring. And of course, like you said, when you have the lack of validation and you have chronic pain, it's very, very challenging. Depression is very, very common. There's also multiple studies that show higher rates of bipolar disorder in people that have hypermobility and associated conditions. So yeah, and that can make it really tricky because, of course, if you're the person examining this person, you're in the in the room with them and you're talking to them, you're probably going to pick up on their anxiety. And a lot of people have had a lot of medical trauma, so their anxiety is only heightened by these previous poor medical experiences. But then sometimes, as we're all humans, right? So we pick up on their anxiety and we can end up kind of thinking, well, maybe some of this is attributable to anxiety, where the anxiety can just be a byproduct or, another thing that they're having to cope with.
Do we have an understanding of how connective tissue disorder can cause such widespread, maybe certain food intolerances, things like if the gut is, the barrier protection is not there? Why do we think it's affecting so many different systems that would seemingly be unrelated to the musculoskeletal system? And, maybe this is a way to sort of start talking about genetics. We said we don't have a genetic diagnosis for hypermobile EDS yet, but I'm curious your thoughts.
Yeah, there's multiple different theories on that, and some of them have to do with interoception. So people who have high levels of interoception are, acutely aware of things that are going on in their bodies. So, like, I know I feel all kinds of things in my body that my husband doesn't feel. Like, I feel like he's almost like clueless about what's going on in his body, and I can feel everything, like everything. So there can be differences in that. There's been some studies that have shown that the amygdala is larger in people who have hypermobility. So that, of course, would contribute to higher levels of anxiety. There's something called the neuroconnective phenotype that some researchers have looked at. It's possible that genes that are responsible for joint hypermobility and genes that are responsible for things like autism and ADHD, that there's some overlap there. There's a number of different theories as to why these things might be overlapping so frequently.
So should we talk about genes? And I mean, as a primary care, if you're seeing somebody you think they might have hypermobile EDS, what do we have to know about genetic testing wise, or what are you sending people for in your clinic?
So this might not be a very popular answer, but if I suspect vascular EDS, then I'm always going to send them for genetic testing. Usually, if I don't suspect a rarer type, I usually don't send them for genetic testing. I know some patients might not like that because a lot of patients, I feel like, really want that. They want that genetic testing. But oftentimes you end up with a variant of uncertain significance or, it comes back negative. So now they don't have any additional information. And I have yet to be surprised, actually. I have yet to have somebody where I didn't suspect anything, but did the genetic testing because they really, really wanted it. And it came back that they had vascular EDS, for example. And I've seen a lot of people be pretty distressed over these variants of uncertain significance. And, they're variants of uncertain significance because we don't know what they mean. So I'm not a geneticist. I do think that in some cases where, it's a really unique presentation, or I feel like, I usually do order the connective tissue panel, not the Ehlers-Danlos panel. So if I'm going to have, kind of a little bit more of an index of suspicion, oftentimes I will order that. But if I feel like there's really some things that don't really seem to fit, maybe there's some early hearing loss in the family and some other things, or I think, gosh, this seems like this might be, a different type of connective tissue disorder, oftentimes I will send them to a geneticist. I'll start working on different therapies because it can take a really long time to get in to see a geneticist.
Thank you.
Yeah, I guess my broader question is who in your experience, and I imagine there's a lot of geographic variation, but who tends to own this or make this diagnosis? Like oftentimes I will inherit the patient who comes with an anecdotal diagnosis of hypermobile EDS or a self-reported diagnosis, but like I don't know that I've seen it commonly sort of made in the primary care office, like, oh, I'm fairly certain this generalized, joint hypermobility or that kind of thing. Like in part because I think the classification system is absolutely bewildering, at least to me. So I guess who typically works this up and kind of figures this out? Does this happen in the primary care office? Is it done by sort of people with special expertise like yourself, or how how should we expect to see this diagnosed, and how does it typically happen?
That is such a great question. I think one of the challenges is that EDS or connective tissue disorders don't really belong in any one single specialty, right? So, they can benefit from seeing a neurologist for some of their problems. They can benefit from seeing physical medicine and rehabilitation. They can benefit from an internist and a gastroenterologist, right? Allergy and immunology. I'm an anesthesiologist. I'm an accidental EDS specialist. I did not plan on doing this, but I couldn't work in the operating room anymore due to my bone grafting surgery on my left wrist, which is my airway, hand. And so I ended up opening a clinic, and I ended up first learning about EDS as much as I could to help myself. Selfishly, that's what I was doing. And along the way, one of my colleagues convinced me to open a clinic. So I would say that probably a lot of the people that are doing this are like me, where they're kind of accidental specialists. So they could have all kinds of different backgrounds. In fact, I know of an ophthalmologist, believe it or not, who no longer practices ophthalmology because of their EDS, but they started learning about EDS and actually see patients for EDS.
I think a lot of innovation comes from people who are not native to a field, because you haven't been taught all the same things as everyone else, so you're going to think of problems differently. So I think it's probably a strength in that way. Well, I do want to spend some time just talking about, like, I was reading, and maybe this was the same family practice article Paul was talking about, that sort of the main cornerstones to treatment, and tell me if you agree with this or not, patient education, kind of joint protection, and then symptom management of like all these various kind of things. Do you have pillars? I know you're good about making kind of lists and things like that. So how do you talk to patients about how you're going to get them feeling better?
So I have an acronym that I use for the method that I developed for developing a comprehensive treatment plan.
Mm-hmm.
And the letters are MENS, PMMS, and that stands for movement, education, nutrition, sleep, psychosocial modalities, medications, and supplements. And you'll notice there's 3 M's. And out of the 3 M's, movement is first and medications is last, and that's on purpose. Most people, when they come to see me, they've already tried a number of different medications. So the key is getting them to move better and to move more in a way that feels safe to them and does not create more fear of movement. If fear of movement is very, very common, kinesiophobia. I remember when I first started learning about EDS and I realized, oh my gosh, this is absolutely what's happened to me. I'm so afraid to move because I hurt myself doing small little things. And then what happens? You get sarcopenia, or loss of muscle mass, and your tissues get weaker, and so you get injured even more easily. And you also get deconditioned, which didn't cause your POTS, or postural orthostatic tachycardia syndrome. It didn't cause it in the first place, but it certainly doesn't help when you get more deconditioned. So the movement piece is really, really important. And for a lot of people, it's just really hard for them to know where to start. So I have a lot of resources that I point people to. And for some people, they're already doing quite well, and they just need to find a good physical therapist that can help guide them on some specific exercises. Sometimes working with a personal trainer or a gyrotonics instructor or a Pilates instructor, can be helpful. I do generally tell people to be careful with things like group classes, because you can end up pushing yourself more than you should and, end up with an injury as a result. And then the E for education is really, not just education about these specific conditions, but about central sensitization and nociplastic pain, because that's something that happens very, very commonly with people that have EDS. And I feel like that was a huge aha moment for me when I first learned about nociplastic pain, because I literally realized, oh my gosh, that's what's happened to my nervous system. I was in the operating room and I was getting more and more sensitive to the OR lights. Like, I could no longer look at the incision without losing my vision completely. I wouldn't be able to see anything after that, for a brief period of time, of course. But you get this light sensitivity, sound sensitivity, all of these things that happen in your nervous system. So understanding that can be really helpful and can help you to stop blaming yourself for all these weird things that are happening in your body. And then the N stands for nutrition. So, eating a diet that's which when I say diet, I don't mean like diet as in to lose weight, but I mean the type of foods that you eat, keeping it as close as possible to real food, which can be challenging because sometimes people can't stand up long enough to actually make a meal. But, I help them kind of sort through those things. And it's not as simple as just, don't eat any high histamine foods because some high histamine foods are fine for some people with mast cell activation syndrome, and other people with mast cell activation syndrome can't tolerate those high histamine foods. So it's not just like follow an anti-inflammatory diet, which can include some high histamine foods, or just follow a low histamine diet. It's kind of very personalized in terms of what's going to work for that specific person.
Can I ask a follow-up about that? Do you
Of course.
have a nutritionist or a handout? I've never heard of high histamine or low histamine foods, so I wouldn't even know where to start with that.
And a couple of them are spinach and avocado, which, those are
I'd be
great.
dead.
Yeah,
If I-
yeah.
Oh, the millennials. Oh, no.
Yeah. So those are great foods. So that's where it's a little tricky, for some people. But that's why I say don't just look up what high histamine foods are and take all of those out of your diet, because a lot of people do end up getting overly restricted. So I try to approach this with an abundance mindset, and you need to feed your body these nutrients. And yes, you might have a gluten sensitivity, even if you don't have celiac disease, but then keep in mind if you're going to take gluten out of your diet, then you might be missing some things like B vitamins. And so I give them a fair bit of education about nutrition. I do have a variety of handouts that I use. Sometimes I do recommend specific dietitians that I work with. It just kind of depends on where they're starting from. When I see them for the first time, I do have them fill out a food questionnaire, so I get a pretty good idea of what they're eating. And no surprise, people have very, very different habits. So that's kind of our starting point.
Okay. So we're at the men on men's PMS.
Right.
What's
right.
what's the first S?
So the first S stands for sleep. So you probably have both heard of painsomnia. So you're hurting, so you don't sleep well. And then because you don't sleep well, now your pain is worse. So this is a very, very common problem. So I'll work with them to try to improve their sleep. I'll work to figure out, do I think they have sleep apnea? Do I think they need to be worked up for that? And, trying to also get them back on a better circadian cycle. So sometimes, people are going to sleep at, 2, 3 in the morning, and that really throws everything off.
Yeah. Okay. For interest of time, we'll skip all the circadian rhythm stuff. But all right, what else? So PMMS is the rest of it.
Right. So the P stands for psychosocial.
Mhm.
I find that it's very, very common for people that come to see me. Of course, they're coming to see me because they're having a lot of pain usually. It's very, very common that they'll have some kind of traumatic events in their past, which may or may not be resolved. And so it's important to address that and try to work through those kinds of things as best that they can.
Mhm.
And sometimes that's through EMDR, sometimes eye movement desensitization retraining, sometimes it's through things like DNRS, dynamic neural retraining systems. I also love the Gupta program. And so, some of these things can be very, very helpful. There's a whole host of different programs like that people can do, a lot of things that people can access online, which is great. And also, it's looking at their supportive networks. So a lot of people, they don't have supportive people in their life to really help them with this. So sometimes, it's helping connect them to support groups and things like that, where they can get some camaraderie and feel like they're not alone. Then the next letter M stands for modalities. So that could be using like a vagus nerve stimulator that can help calm anxiety and improve symptoms of dysautonomia or POTS. Sometimes it could be using, something like ultrasound, although that's not as common as it used to be. It could be using like virtual reality. So, a lot of pain clinics are using virtual reality goggles and finding some benefit with that. So it could be myofascial release, massage, acupuncture, acupressure, variety of things. The next M, or the last M, stands for medications. And probably the most common medications that I prescribe are low-dose naltrexone, which is an opioid antagonist, but in low dose can actually act on glial cells in the brain and reduce neuroinflammation. I also prescribe ketotifen, which is an antihistamine that is also very anti-inflammatory. And the third most common thing I prescribe is cromolyn, which is a mast cell stabilizer. Then the last letter, S, stands for supplements. And I often will prescribe vitamin D. I'll check a vitamin D level first, of course, and then I'll prescribe vitamin D. Sometimes I do prescribe magnesium, although I don't usually check a level first because levels are just not that accurate for magnesium. Some other supplements that I often prescribe are quercetin, spelled Quercetin, and that's an excellent mast cell stabilizer and anti-inflammatory flavonoid. And another one is palmitola ethanolamide, or PEA. So those are some of the common supplements that I prescribe.
Man, Paul, I feel like I could spend an hour asking about some of
Yep.
these last few comments here.
Well, I guess, I mean, this actually feeds into a question I wanted to ask about in terms of, I feel like this is a patient population where it would be very easy to see a prescribing cascade, right? Like you're trying to
Yes.
treat multiple symptoms, and then you're treating with multiple medications. So they're invariably on antihistamines, and so they're dry mouth, but they're sleepy all the time. So I'm going to give medication to help with that, and then medication to help with that side effect. Next thing you know, the medication list is 20 things long, and
Yes.
they don't feel any better. I guess I would like to hear your approach in terms of how to be mindful. Or is there utility in deprescribing? I guess just sort of broadly, if you could talk to, I mean, the supplementation stuff is helpful, but in terms of, I mean, you've already touched on some of this, and I might not even have a specific question here, but I feel like I see so many patients that are on 74 medications because they're treating the other medication side effects. And how do you approach that in general with these patients?
Yeah, if I see somebody who has already a long list of medications and or a long list of supplements, I start talking to them about excipients. So excipients, the inactive ingredients in medications, are not inactive for these patients. So it could be that some of their symptoms are related to excipients. So I say, you know what, we need to get you off as many of these things as possible before we can consider adding something. Because, I mean, we know that how many randomized controlled trials are there looking at these different combinations of drugs that these people are often on, myself included. I mean, I was on a lot of different medications. And so the deprescribing is very, very important. And of course, it takes buy-in. Not everyone is keen to do that right away. But, I just start with, okay, well, why don't we try identifying 5 supplements that we think maybe we can do without, and we'll stop each one, one at a time. And also, I also tell people, don't stop at the end of a bottle, because if you stop and you're like, wow, that actually was making a huge difference, now you don't have any left. So I tell them, stop when you have maybe a fourth of the bottle left, so that way, if you stop and now your symptoms increase, at least you have something that you can restart.
Can I ask a little bit about, because you were an anesthesiologist, presumably you might not have been using, I don't know, were you using vagus nerve stimulation or prescribing, what did you say it's called, quercetin? And how did you sort of identify these treatments? Because a lot of us listening, myself and a lot of people listening to this podcast, like we're used to all the meds that you can order up in your electronic health record that we were taught to prescribe in medical school. So how did you sort of go about like developing this regimen that you have been using for your patients?
It really evolved over quite a significant period of time. So for me, my health really changed dramatically in 2009 when I fell off a mountain bike. And before that, I was literally in the best shape of my life. I was in fantastic shape, and I was training for this mountain bike race. I should not have been mountain biking. I should have stuck to ballet.
That's riding at high speed down hills with rocks and obstacles,
my gosh.
right?
Yeah. And I was going over logs, and I mean, it was just crazy. I don't know what made me think that this was a good idea. Well, my husband was doing it, and I thought, this is a fun thing to do with him. So
this guy seems to cruise through. Paul, what's your impression of her husband based on this? He seems, he's a great guy.
He seems awesome. Is the first thing. I mean, he's like the Spuds McKenzie of whatever it is that he does. But then also, I was just going to say this again points to every single one of our guests being poorer than we are, Matt. Like this is in keeping with a much larger pattern.
Well, the funny thing is, he's a urologist, and I keep trying to get him on my podcast, to talk about various different things. He's retired now. He's retired from clinical practice, and he does some consulting work, but he is a great guy. But yeah, he's sailed through so many different things. He'll get injured or whatever, and he just, it doesn't faze him. So we're built very, very differently. But it kind of, going to conferences and participating in a lot of, integrative medicine, and, I'm not certified in functional medicine, but I've taken a lot of the courses, done a lot of reading, and just trial and error, on myself and with patients, saying, hey, this can help with inflammation. Maybe it's something worth trying. Should we try it and see how it goes. And, then you see what things really make a difference. And those are the ones that you stick with, like the low dose naltrexone. I've been taking that now for about 8 years, and I really think it's made a huge difference. And I think for most of my patients, that's been the biggest thing.
So, Linda, I wanted to ask, or at least mention, some of the things that you prescribe have to deal with sort of mast cell stabilization. I think cromolyn is like an old school asthma med, if memory serves. And you talked about sort of low histamine foods. All this is, we sort of been dancing around the fringes because I've been scared to ask directly about it, about this mast cell activation syndrome, which I think we did say out loud once. But just for our listeners and for me, could you just sort of maybe briefly tell us what that is and why the mast cell stabilization is important, and sort of how that helps symptomatically and how you think about approaching that?
So I will say that my view of this changed dramatically from when I first opened my clinic in 2017. I thought, okay, this is going to be treating people that have EDS, and then a small number of them are going to have mast cell activation syndrome. And I now think of mast cell activation syndrome as being on a spectrum. So mast cells, a part of the innate immune system, are something that we have to have. They're essential for life. They're important for, when we have an infection and exposed to various different environmental things, both internal and external. And when they're abnormally triggered, when they're like super, super sensitive, that's when we have mast cell activation syndrome. So we generally think of them causing inflammation, allergic type phenomena, and abnormal tissue growth, which fortunately is usually benign. So mast cell activation syndrome is probably a lot more common than most people realize, and can actually contribute to sensitization of the nervous system and contribute to pain. So I also realized when I started focusing more on stabilizing mast cells and mast cell-directed therapies that my outcomes got better, people's pain got better, and so that's why I really like that combination of 3 medications.
And the 3 medications, so this was low-dose naltrexone, ketotifen, which is an antihistamine, and cromolyn, which they sell like a cromolyn nasal spray for allergy symptoms, I know, at your local drugstore. The low-dose naltrexone, so naltrexone comes in, is it 25 or 50 milligram
50.
tablets, Paul?
50, yeah.
50s. So you're compounding this? Tell us about that.
Right. I'm compounding it. I either start people usually at 0.5 milligrams or 1.5 milligrams, and I will prescribe them, pretty good number of tablets or capsules, ideally tablets, because then they can split them in half if they need to. And I usually have them go up by 1 pill. So if they start at 0.5, they go from 0.5 to 1 to 1.5, every week. So if I prescribe the 1.5s, which, I would do for probably most people that aren't super, super sensitive, I'll prescribe the 0.5s for people that say, oh my gosh, I'm just like so sensitive to everything. So that's kind of how I decide that. And then I also will let the pharmacy know, the compounding pharmacy, of known excipient reactions. So if the person knows that they're sensitive to certain, capsule types or fillers and things like that, I'll let them know about that. And then the maximum dose does vary, and most people usually land around 4.5 to 6 milligrams. That tends to be a good dose for a lot of people. But I do have some patients where, for cost reasons, they want to get to where they can take a 50 milligram tablet from the regular pharmacy and split it into quarters. So they're taking 12.5 milligrams at night. So I do have some patients that are doing that, and they tolerate it well.
Do they have to generally get titrated slowly up to that point?
Yes.
Or is that where they, okay, gotcha.
Yeah. Naltrexone's an interesting one, right, Paul? Like we were talking about sickle cell, and sometimes they put naltrexone in the PCAs because it helps with like itching. So I don't think I understand naltrexone as like how it would be involved in this. We heard about that, Paul. I don't know if you remember. That was like years ago. And so
that's one of our live brand rounds, if I'm not mistaken.
Yeah.
Yeah, it is very, very interesting. So there's ultra low dose naltrexone and there's low dose naltrexone. And if you're doing the ultra low dose, like
you just leave the bottle under their nose.
Yeah, right. Exactly. So you might be starting at 50 micrograms or 100 micrograms per day, but that you can do with opioids. I usually don't do that. I usually am waiting until I can get somebody weaned off of opioids, and then I wait at least a week, maybe 2, depending on how long they were on them for, and then I start the low-dose naltrexone.
Are the ketotifen and the cromolyn just over the counter or prescription?
Unfortunately, the ketotifen is also compounded. even though
Okay.
it's an old antihistamine. It's been around for a long time. And cromolyn is actually currently kind of hard to get. You can get it from a regular pharmacy in these little vials, and you take it about 15 to 20 minutes before you eat a meal. But sometimes people do get it compounded either because of excipient reactions. It's in these plastic vials, so it could be the plastic that they're having a problem with, or if they can't get it from a regular pharmacy.
Yeah. I mean, this is very niche. You have, I mean, this is a very unique practice that you have, is what I
Mhm.
should say. And what's the experience been like? Most patients coming to you, are they coming to you having seen 5, 6, 10 other people? I mean, like, what is the
Yeah.
typical?
I had a patient the other day who's estimated that she had seen 80 different doctors before she saw me. So, I mean, that's
Yeah.
more than usual. But a lot of people have seen 20, 10. I mean,
Right.
the numbers are usually really high. Those are probably very conservative estimates.
Yeah. Well, we wanted to do this because Paul's starting to see this in his practice, for one, but also we've been getting, as someone who gets our listener emails for many years now, going on a decade, this has been a
Wow.
topic that has kind of come up repeatedly, like people requesting we talk about this. And, it just seemed like, now I met you, and it seemed like this was a good time to do the topic. So we're really glad to speak with you about this, and I look forward to seeing how this evolves over time. We try to be ahead. We try to be ahead of the curve, right, Paul?
Mhm.
With what we're featuring on the show, what we're trying to learn about.
Yes, absolutely. We're cutting edge stuff. I do want to ask. I'm trying to think of the right way to frame this. Again, just because you mentioned the point that it's sort of delays in diagnosis and seeing a lot of providers before actually having the diagnosis confirmed. The role of self-diagnosis is what I'm trying to get at here, and
Mm.
especially with sort of the rise of social media and TikTok specifically, and there's a lot of information out there, and some of it's actually quite good, and some of it is less quite good. I guess, how often do you see self-referrals or self-diagnosis, and sort of what are reputable or more solid resources that we can sort of point patients to, so that they can educate themselves, and actually so that we can educate ourselves about this?
Yeah, it's I'm so glad you asked this question because it really has become kind of like a gold rush. You see people putting the word hypermobility on their website because they know that it's a topic that patients are very, very interested in. I started my own podcast on which I was so honored to interview Matt and talk about the role of an internist in this type of situation because I think so many people don't understand. And I've had patients who, they'll say things to me and they'll say, "Well, yeah, I'm thinking of getting a new internist." And I say, "Well, why?" And they say, "Well, when I mentioned about EDS, they didn't know how to pronounce it or they looked it up." And I was like, hang on. Let's talk about this. Like, do you understand all the things that they need to know about? And that's great if they looked it up. I mean, that's amazing. So I try to educate people about that on my show called Bendy Bodies. And I started my podcast not 10 years ago, but going on when did I start it? 2020? Yeah, February of 2020. So it's been 5 years. And I did that because I wanted there to be accessible information about these conditions because there is this misnomer that because there's no cure or because there's no, magic pill, everything I discussed, by the way, is off label. There are no on label FDA approved treatments for POTS, and there are no FDA-approved treatments for EDS. So everything that I discussed is off-label, but these are things that a lot of us are using. So I started using the podcast like you guys do as a vehicle for sharing information and helping people to realize that there are things that you can do to help yourself feel better in so many cases. And the nice thing is, a lot of these things are they're quite safe, and things that people can do on their own, even if they don't necessarily yet have a healthcare professional that can really help them. Of course, not the prescription medications, but some of the other things they can start finding resources themselves.
Fantastic. Well, Paul, what do you want to conclude our case, and should we go to take-home points?
Sure, absolutely. So let's give Miss Smith a happy ending. We refer her for physical therapy. We encourage aggressive hydration and ask her to at least to increase her salt intake to help with some of her POTS symptoms. We encourage her to remain physically active in a careful way, but not too careful, and avoid triggers for her dysautonomia. Hot showers were mentioned in multiple papers. I think there's sort of one particular writer who mentioned that the hot showers can set off POTS symptoms pretty significantly for a lot of these patients. But regardless, Ms. Smith is grateful to have her symptoms validated and have a diagnosis that can begin to be addressed. So we'll give her that particular happy ending. So we talked about resources, but I guess actually let's go back to the beginning and ask you any take-home points for our listeners that you'd like them to leave this episode with.
Definitely. And do want to point out that the hot showers are also a trigger for mast cell degranulation. So people can get, a mast cell flare when they're taking that hot shower, and that's going to cause their, capillaries to be more leaky, and that can also contribute then to the dysautonomia type symptoms and, feeling hypotensive and or being hypotensive, I should say. So that definitely is something that a lot of people struggle with for sure. So the first thing I want to say is that symptomatic joint hypermobility. So when you have joint hypermobility and symptoms that are likely related to that joint hypermobility, that is not rare. We don't know how common that is because you'd have to add up the Ehlers-Danlos syndromes and other conditions like Lewy Dietz and Marfan's and things like that. You'd have to add in all the people with HSD, and there's so many people that have not been diagnosed. So I'm not talking about my friend who's 65 and in incredible shape. She does not have symptomatic joint hypermobility. She has joint hypermobility, without any problems or symptoms. But a lot of people are pre-symptomatic. They're young and they haven't had any problems yet, but we don't know if they're going to develop problems. So this is really definitely not rare. And there's many, many different causes. So there's a saying in the anesthesia world, all that wheezes is not asthma, because we have to think about congestive heart failure and all these other potential diagnoses. And I like to say all that is hypermobile is not EDS. So we need to remember there's lots of other, potential causes. So that's the first thing. The second thing is the importance of validation, as you said, Paul. So important. I used to teach a course for a medical school called The Healer's Art. And in that course, I would teach medical students that listening is doing something and the importance of listening. And it wasn't until I opened my clinic that I really realized that really is true. And it just, I think we go into medicine because we want to help people and we want to fix them and make them feel better. But even if we don't have something at that particular appointment, if we listen to them, if we validate them, and if we say, you know what, I would like you to come back and let's have a second conversation about this or a third conversation or whatever. I want to see if I can come up with some other, ideas. I think most people really would respect that and really appreciate that. So that validation piece is really important. The third thing is that there are treatments available. So important to have resources available for people so that they can get some treatment and hopefully improve their quality of life and improve their functional capacity. And last point I want to make is that diagnosis is very important, even though there is not a cure. So a lot of people, will say, well, the diagnosis doesn't matter because there's no cure for these conditions. But like with the validation piece, having a diagnosis is really, really helpful for people.
All right. Well, thank you so much. I learned a ton here because almost all of this was brand new information to me. So thank you for spending so much time teaching us tonight. We really appreciate it. And people should check out the Bendy Bodies podcast. They can learn a lot more about this world, this topic, if they're interested.
Absolutely. Thank you so much for having me. It was so great chatting with both of you. I love your show. I think it's so terrific. And I think the work that you do is so important. So thank you for having me.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy?
Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we need your feedback, so email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Special thanks to our writer and producer for this episode, Dr. Paul Nelson Williams, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.